macular diseases as a group are, diseases that can seriously impact vision and seriously impact quality of life. And a lot of them are very time sensitive, that we need to diagnose these things and treat these things early to prevent problems. So, if someone is noticing a change to their central vision, if they've got an Amsler grid that they're monitoring, we want to hear from patients early if something's changing. So sometimes patients say, oh, look, I didn't know whether I should call. I didn't want to waste anyone's time, that sort of thing. As eye care professionals, none of us are going to be upset with a patient who's noticed a change and wants to get it checked out. We'll actually be very happy if it's something that's quite minor and doesn't need anything done about it. That's fantastic. We're all, everyone's happy. But at the same time, we'll be thrilled if we can catch one of these things early, and save vision that otherwise would have been lost. We're all in this game because we care about people's vision, and because we want to help people maintain their best vision for their entire life. We're all in this because we want patients to see well. So the take-home message is never be worried that you're wasting our time calling us about these things. If you're worried about your vision, I'm worried about your vision. So get in touch.
If you've ever looked at an Amsler grid, those little boxes of straight lines, and noticed that some look bent or wavy, it's natural to worry that it might be macular degeneration, but that's not always the case. In fact, several other conditions can cause the same type of distortion, things like macular holes, epiretinal membranes, or vitreomacular traction. Today, we'll unpack what's really happening when your vision looks wavy and how eye specialists can tell the difference using advanced retinal scans. I'm joined again by Dr. Mitch Lee, ophthalmologist and co-founder of Eagle Eye Surgeons in Sydney, to explain what these conditions mean, when treatment is needed, and what recovery typically looks like. But first of all, who am I? My name's Paul Salloway. I'm the owner of Optics Digital. We're an agency that helps eye care professionals to grow their practice. So, hi, Mitch. Good to catch up with you again.
Hi, Paul. Nice to see you again.
So, that Amsler grid, that's I think it's something that people can do at home, and a lot of people may do that and see the some wavy lines or some distortion in their vision. And I think that maybe the first thought in a lot of people's head is, oh, it's macular degeneration, but actually there are various things that, as we'll talk about, which various other things that it could be. Is that right?
So the Amsler grid is a test of central vision. So it's just, we use it as a way for patients to be able to check their vision at home, because especially when you're moving around day-to-day life with both eyes open, if one eye is a little bit off, you might not notice it. Whereas doing the Amsler grid, forcing yourself to go one eye at a time and just check that, just lets us pick up any problems of the macula as early as possible. So, traditionally it's been a way to screen for wet macular degeneration, but any problem with the macula, the very central part of the retina, will show up there. So whether it be swelling from diabetes or a retinal vein occlusion, or any of these what we call vitreomacular interface disorders, which is what we're talking about today. As you said a little bit earlier, this is a talk full of things that are hard to pronounce. So we'll do our best.
We'll use lots of acronyms today, I think.
Yeah, exactly. Well, ophthalmologists are attention deficit. We love our acronyms. But yeah, so the Amsler grids are used for any condition where we're concerned about changes in the macula, just because it helps patients to pick up changes in their vision as early as possible, so that they can let us know about it and we can get them in and have a look and hopefully pick some of these things up before they cause permanent damage.
Okay. And so how can patients tell if the distortion that they're experiencing is coming from the macula versus something else, like a lens issue or refractive issue?
Well, generally, so most of those other things like refractive issues, so problems with the lens, problem with the surface of the eye, problems with the focusing of the eye, they'll generally cause blurring. So either just everything's generally blurry, or maybe you're getting starbursts and halo light sources and things looking smeared, whereas they won't tend to cause what we call metamorphopsia, which means the actual waviness and distortion of straight lines and jumbling of letters, that sort of stuff. Those features, those things where a straight line looks wiggly or where everything looks kind of pinched into a point, that kind of distortion is very distinctive and really points us towards a macular problem, whereas the kind of generalized blurring can be caused by lots of different things.
Okay. And does everyone with wavy vision need to see a specialist right away, or are there cases where it's just something that'll settle down on its own?
Generally, if it's new metamorphopsis, so new waviness in the vision, that's not just kind of blink and it clears. If it's this waviness that's there all the time on the Amsler grid, maybe you check and think, oh, that's a bit unusual, and yeah, blink a little bit, put your lubricating eye drops in, and a couple of minutes later look again and it's still there. If it's new, you really need to get someone to have a look at that, because we don't want to muck around with macular problems. They can be, not all of them, but some of them can be potentially very serious and vision threatening, and we really want to get on top of these things as early as possible.
Right. Okay. All right. So let's talk about posterior vitreous detachment, or PVD for short. So what is it, and who does it affect? My understanding is that it's a natural process, and some people may experience floaters and flashes when it occurs. So could you tell us a little about what it is and what happens?
Yeah, absolutely. So look, for this, we just kind of need to go back to the basic anatomy, just because it makes more sense and we understand what's actually going on inside the eye. So see if I can point at the screen. There's our little eye model. I'm trying to hold bits so it doesn't all fall out in my lap. But front of the eye, lens and cornea up front, and this is the vitreous cavity, so the back part of the eye that's usually filled with gel. So the gel in the back of the eye is actually collagen, which is the substances in all of our connective tissue. But in most of our connective tissues, they're very, very high in collagen content, not much else. Whereas the vitreous is relatively low collagen content and lots of water. So it's got the consistency of jelly, but it's actually a form of connective tissue. That vitreous has important roles in the development of the eye. So when a fetus is developing, the gel has a role in supporting blood vessels that are going to nourish the developing structures inside the eye. But once the eye is developed, that gel doesn't really have very much of a role anymore. It does a few things in terms of, we think it's got some roles in assisting with oxygen diffusion into tissues and some other bits and pieces, but nothing that you can't do without. And we know that because when we do a lot of retina surgery, the first step is removing the gel from inside the eye, because we can't work on the retina when it's still there. And we know that when you do that, it doesn't have any serious long-term impacts on the eye. So really, it's a tissue that has a role in development of the eye, but doesn't do much for the rest of your life other than just be there and potentially cause problems. So that gel, when you're younger, is fairly well formed. It's a discrete gel-like substance, but over the course of your life, it gets more and more watery over time. And eventually, it gets so watery that it starts to separate away from the retina at the back of the eye. And in normal development, what should happen is that gel should just very gently peel away from the retina and float harmlessly within the eye without anyone noticing that it's ever happened. A small number of people will have the gel tear a little bit as it comes away and throw up debris into the space inside the eye, which is what we see as floaters, just little black or specks or little wiggly worms and things in the vision. Some people see them as clear things or grey things or black specks. That's all a little bit different. And it can also cause flashes of light, whereas it's separating away and tugging on the retina a little bit. It irritates the nerve fibres and you perceive that as a flash of light. The reason we worry about these things is because those symptoms are exactly the same as the symptoms of a retinal tear and potentially a retinal detachment. So even though posterior vitreous detachment is normal and happens to everyone at some point in the course of their life, it can cause problems. And we want to identify the people who may have those problems. So there's no way for an individual to tell whether the flashes and floaters they're seeing are just normal from the posterior vitreous detachment or whether there's a tear there. So if we get those symptoms, we want you to come along and either to us or to an optometrist or someone who can have a look in the back of the eye and just confirm that all it is the gel coming away and not something more serious.
Okay. So you likened it to cataracts as something that, most of us are going to naturally experience. In the case of cataracts, though, like eye care professionals will sort of give you advice on the things that you can do to prevent them or slow it down. Do you give advice to patients on PVD in a similar way? Like, is it something that, can be or should be prevented, or is it just something
Well,
that's, it's going to happen?
cataracts, yeah, that's a good question. I mean, cataracts, the reason we try to slow down or prevent cataracts is because of the fact that they need something done about them. So,
Mm.
once you get enough cataract, it does actually start to affect your vision. Whereas posterior vitreous detachment, yes, it's the highest risk period for developing a tear in the retina, but we know that most people don't, and it doesn't have any long-term impact on vision unless you get some floaters with it. And really, it's not something that we look at as needing to be prevented. Though ideally, we want to make sure that it happens in a controlled way rather than suddenly, and that's why we say, don't. We try to avoid eye trauma. So, getting punched in the eye or hit in the eye is really not good for you for lots of reasons, and one of them can be that it can trigger an early posterior vitreous detachment that could be forceful enough to cause a tear in the retina. And so things like bungee jumping and that sort of thing can do the same thing. I'm not going to go out there and tell people not to do these things, because we know that plenty of people do them and don't have retinal tears or detachments, but particularly for patients who are already at high risk of those conditions. So someone who's had previous eye injuries, or someone who's very, very short-sighted and we know is at high risk of retinal detachment, or someone who's got a big, strong family history of it, they're the patients that we say, look, bungee jumping might not be for you. There's lots of other fun adrenaline sports you can do, but maybe don't do that one.
Okay. Right. So if I'm hearing it correctly, so you're saying that for people who have a high risk of retinal detachment, for example, then they need to be a little extra cautious.
Yeah, exactly. And it's just because, like I said, we know that the gel coming away from the back of the eye is a time when all of us are at increased risk of developing a tear in the retina because things are changing. And so anything that can force that process to happen earlier than it was going to, or with a bit more force than it was going to, can be risky for people who are already at increased risk of tears and detachments.
Okay. So we've talked about PVD and how that's a natural process. You said that in some rare, in a few cases, people might experience flashes and floaters, and you mentioned to me earlier that in even fewer cases, some people might have issues. One of which could be a macular hole. So let's talk about that. So what is a macular hole, and how can it be treated?
Yeah, so the macula is the central part of the retina. It's the area of the retina that's got highest visual acuity. So it's where all of your conscious vision comes from. And at the very center of that macula is what we call the fovea, which is an area of the retina that's extremely thin, but it's the area that gives you the highest acuity vision. So it's what allows you to have reading vision and to thread a needle and see those really fine details. The problem is that the retina is very thin there and very fragile there. And so there's a few different things that go on in macular hole, and there is a little bit of debate as to the exact mechanisms that cause macular hole. It's probable that there's a few different things that can do it. We know that one mechanism, and we know that because we see it in patients that we watch over time, when the vitreous is starting to detach, when that process of posterior vitreous detachment is happening, there are some of us that, for whatever reason, have a vitreous that's just a bit stickier than it should be. And so instead of coming cleanly away from the retina, it can stick in one particular area and pull on the retina as it lifts away. Now, if that happens out in the peripheral part of the retina, that's how you get retinal tears and potentially retinal detachment. But if that happens over the macula, then as it pulls away, it can cause something called vitreomacular traction, which we'll talk a little bit more about later on. But if all of that traction is concentrated right at that very central thin part, the fovea, then as the gel comes away, it can actually pull a hole in that thin area of retina. And that's what we call a macular hole. And so when a hole happens out in the peripheral parts of the retina, that's not an area that's useful for vision. So it doesn't cause any problem with vision in and of itself, but it can cause the retina to detach because the hole in the peripheral part of the retina can allow fluid to track in underneath the retina and cause it to detach. In the macula, the hole in the middle of the fovea, that is an area of retina that's useful for vision. And so when you develop a hole in the macula, it affects the central vision. And so what patients will notice is that they'll be able to tell it's maybe not the split second it happens, but generally over the course of that day, they'll just suddenly become aware that the vision just doesn't seem as clear in one eye. And if they go and check with one eye, maybe check their Amsler grid, they'll notice that they've got a blurry patch in the very center. Sometimes they just describe it as a little area of blur, and as it gets bigger, they may see just kind of a grey blob in the center of the vision where they know there should be, normal vision at the very center. There's just an area they're not seeing very well, either blurry or grey. And that's because of the fact that a hole is formed in the retina. And because the macula is like the film in the camera, if you develop a hole right in the center of the macula, it'd be almost like making a cigarette burn through film in an old analog camera. That, no matter what picture you take, there's always going to be that hole in the very center.
Okay. And so how do you treat it as an ophthalmic surgeon?
So macular hole is it's one of those conditions that really needs urgent treatment. So something like a cataract. Cataract, decreases the vision, but we know that as soon as you have that cataract operation, the vision will be back to where it started. Whereas with a macular hole, the longer we leave it, the more damage is occurring in the tissue. And so the longer it's left, the less likely we're going to get back to normal vision. And in fact, the hole forming in the first place generally means that eye is never going to be quite as good as it was before the hole happened. If we get in there really early, we can get it back to the point where the vision is very, very good, but you can generally always tell that eye is not quite as good as the other one. So unfortunately, some of that damage is just not something that we can repair at the moment. But we need to get in there ideally within. So the international guidelines say that we should be aiming to get the operation done within about 4 weeks of onset of symptoms at the absolute maximum, and the earlier we do it, the better. And so within the realms of safety, because we don't want to be doing very fine detail surgery. We don't really want to be doing this in the middle of the night when everyone's fatigued and we all need our concentration. So it's a balance between getting the surgery done safely, but also doing it quickly enough that we're not allowing more damage to occur in the back of the eye. And so it is a condition that needs an operation, and that operation is what's called a vitrectomy. So vitrectomy means removal of gel from the back of the eye. It's removal of the vitreous. And so if I go back to our eye model, it's keyhole surgery. So we make tiny little cuts in the white part of the eye towards the front. And that allows us to pass little instruments into the cavity of the eye in the back to remove the gel and work on the retina. The incisions made for this are basically needle puncture incisions. So most of the time, our workhorse instruments for this are what we call 25 gauge instruments. So if you imagine for anyone who's familiar with needle gauges, 25 gauge is absolutely tiny. It's smaller than the needle you get your vaccinations through. And we've got instruments small enough that we can pass through those little ports, remove the gel, and then remove what we call the internal limiting membrane, which is the surface layer of the retina. It's not a cell layer. It's again another connective tissue layer. But the reason the macular hole remains open is because of scarring that forms in that internal limiting membrane. So that membrane has the scarring forces that are holding the hole open. So by removing the membrane and then putting a bubble of gas in the eye, where we remove the forces holding the hole open, and the gas bubble helps to gently push the edges of the retina back together to seal the hole. Because the retina is extremely sensitive tissue. We really don't want to be touching it directly or manipulating it directly because we can cause damage. And we're talking these holes. We're talking about holes that are usually anywhere between 50 to 100 microns in size and 400 microns in size. In fact, we would consider a very large macular hole to be anything bigger than about 400 to 500 microns, which is half a millimeter. So we're talking very fine detail stuff here, which is why we need such small instruments and why we want to be being as minimally invasive as possible.
Okay. Now I'm a little bit confused about something. From my reading, when I've read about the recovery process after this type of procedure, some say that you have to remain in a face down position, and then others don't say that at all. So I'm just wondering, what does the recovery process look like for macular hole treatment?
So look, a big part of this depends on how big the hole is. So like I said, the key part of the operation is removing the internal limiting membrane and then putting this bubble of long-acting gas in the eye. So we usually use a gas called sulfur hexafluoride, SF6, and that's a gas that stays in the eye for about 2 weeks. So the gas is put in as a bubble in the back of the eye where the gel was, and over the next couple of weeks, it gradually dissolves into the bloodstream and is removed by the lungs. You just breathe it off in your breath, and that allows the eye to slowly refill with the fluid that's usually in the front chamber of the eye. The gas bubble, so we do want it to hang around for at least a few days because that's what's helping to push that hole closed. So once the operation's done, we need the gas bubble to sit in contact with the macula to help create that surface tension and that pressure that's going to try to push the hole closed. And because this is a bubble of gas, it floats on water. So by going face down, we're ensuring that as the bubble floats, it sits against the macula. So the instruction for just about everyone who's had this operation is you're going to be face down overnight. So that means for the first 12 to 24 hours, you're laying down either with your arms crossed over your forehead or with a pillow under your chest so that the bubble sits properly against the macula. Depending on the size of the hole then depends on how much longer you need to be in that position. So again, this is an area of active research. So if you go back 10, 15 years or so, the advice was generally that you needed to be face down for 3 days or 5 days, sometimes even a week, which was just intolerable. So when they actually studied this, they found that even patients who were doing their absolute best to stay face down for a week were only probably managing to do it for 40 or 50% of the time, sometimes less, because it's really difficult. So these days, we're more likely to say, look, face down for the first night, and then for the next 2 or 3 days, sitting up in what we call reading position. And so that's sitting up but facing the floor. So you can imagine if you had a book in your lap and you're looking down trying to read it. So I usually tell my patients, all right, so the first night after surgery is going to suck. You're going to be face down. It's going to be miserable. You're allowed to get up and go to the bathroom. You're allowed to have a 5-minute break now and then just to, stretch a little bit, but really important that you face down for that night. You're not going to get very much sleep. I'm really sorry. Blame me later. But for the next couple of days, I just want you sitting up and looking between your toes and the skirting board. And as long as your head's in that kind of position, the bubble's still going to be sitting against the macula well enough that it should be able to close that hole. And most surgeons will, these days adopt that process where you're only really doing that for about 3 days or so after surgery. And that's because the studies are showing us that anything longer than that probably isn't doing very much.
Okay. All right. Well, that's macular hole, which sounds like it's an actual perforation. Another condition which I think you'd like to talk about is epiretinal membranes, which I believe are also called a macular pucker. Is that right? So can you tell me about how they form and what can be done about them?
Yeah, so you're right. The epiretinal membranes had a few names in the past, mainly because until we had relatively modern imaging in the retina, we didn't really understand what this was. So sometimes it was called macular pucker, sometimes it was called cellophane maculopathy. It has a few different names, but essentially what it is a membrane of scar tissue forming over the surface of the macula. It generally happens when there's been some sort of trauma to the retinal surface, and this is one of the reasons that it's linked to posterior vitreous detachment and what we call vitreomacular interface disorders, because you can imagine if there's been a little bit of stickiness to the gel and it hasn't come away cleanly, it could pull on the retina a little bit, and as it does release, maybe it's not stuck so firmly that it actually causes a hole, but it still traumatizes the surface as it peels away. Sort of like, when you peel sticky tape off your skin and maybe you lose a few hairs and it looks a bit red and angry underneath. The same thing can happen on the retina. And for reasons we don't really understand, some people are just more prone to developing this scar tissue than others. And I liken it to, the way that some of us get a cut on the skin and it heals over with no effect at all. And you get the same cut on another person and they get a lumpy keloid scar that's really obvious. So there's obviously genetic factors that predispose people to these things. But essentially, it's the body trying to respond to what it sees as an injury on the surface of the retina, either happening during a posterior vitreous detachment or happening due to trauma to the eye or bad inflammation or an infection in the eye, something that's triggered that healing response, and the body's overdone it a bit, and we've ended up with this scar tissue membrane over the surface of the macula. The problem with scar tissue is it contracts. And so if this membrane is thick enough, then as it starts to contract, it pulls the retina with it and it wrinkles it up like, like wrinkles on your shirt. And the problem is, you can imagine if you took the film in a camera and scrunched it up so it was all covered in wrinkles and folds and things and then stuck it back in the camera, you're not going to get a very clear photo. And the same thing happens with the retina. Because it's been pulled and stretched and warped out of shape, the same thing happens to the vision. And so, in those cases where we've got an epiretinal membrane that's symptomatic or is clearly getting worse, even if the patient's not really noticing the symptoms terribly much yet, it's generally worth operating on those to release the traction and let the retina settle back into its normal position to improve the vision.
And so, if somebody gets an epiretinal membrane condition in one eye, does that mean that it's likely they're going to get that same condition in the other eye, or it's really just
not necessarily? It does depend. There are, we do get some patients who develop it in both eyes. We get some patients who only develop it in one eye, and so I would say the majority of epiretinal membranes we see never actually progress to the point that they need something done about them. So when they've looked at how often these things happen, we say, about a 5% risk, maybe 7% risk, over your life of developing epiretinal membrane. But the majority of people with it wouldn't even know they had it. There's, it's there, but it's not really causing much of an issue. The number of patients that I need to operate for epiretinal membrane is only a small proportion of the patients that I see with the condition, because, like we were saying, with scarring on your skin, any cut you get is going to cause a scar, but not that many of them are going to be noticeable. And epiretinal membrane's the same. If it's very mild and it's not impacting on the vision and it's not progressing, then there's no reason to touch it. We just watch it for a little while, make sure that it's not getting worse, and then nothing more needs to be done.
And is the recovery process simpler than macular hole treatment, for example?
It is. So for most epiretinal membranes, the operation, again, it's a vitrectomy. It's the removing the gel from the eye is the first step. And then the surgery, in this case, we're not trying to close a hole in the retina. We're just trying to remove this abnormal scar tissue. And so it's what we call an epiretinal membrane peel. So we put dyes in the eye in the same way that we do with macular hole. So we put a dye in the eye to stain up the tissue of interest. It's a blue dye that shows me where the scar tissue is. And then with micro forceps, I'm able to just gently remove that from the surface of the eye. And removing the membrane itself is enough to allow the retina to sit back in its normal position. So in these cases, we don't need to put a long-acting gas bubble in. Instead, I'll generally do what's called a partial fluid air exchange, where at the end of the operation, I'll put a small bubble of sterile air in the eye, enough to seal up the little puncture wounds that we've made, but not so much that the whole eye is full of gas. And by doing that, it means that the bubble doesn't hang around as long. Because something we didn't really touch on with macular hole is that when you've got a bubble of gas in the eye doesn't work properly. It's like having your eye open in a pool underwater. Your eye's not meant to function with water outside of it. It's meant to function with air outside of it, just the same as it's not meant to function with a gas bubble inside it. And so that makes the vision very blurry until the gas bubble goes away. So, if we don't need the bubble to be there for several days, there's no reason to put a longer acting gas in. So with a partial fluid air exchange, there's a bubble in the vision that moves around inside the eye and is a little bit annoying for usually 3 or 4 days or so, and then it's gone. So again, I usually tell patients, look, just be aware when you come out of the operation, you're going to have this fluid level in the eye. It's going to see, there's going to be a bubble of gas. You're going to see this line across the middle of your vision. And over the next few days, that line's going to get lower and lower. Eventually, it'll form into a round ball that'll drift around inside the eye as you move. And then one morning you'll wake up and it'll be gone. I usually also tell them it's a good chance to level any furniture they've got, because they've got a built-in spirit level at that point.
I see. Doctor's humor there. All right. So finally, let's talk about vitreo-macular traction a little more. So you said that's the process, or that's something that happens when the that gel gets kind of stuck to the back of the eye, to the retina, to the macular, I think you said, and starts to pull away. When is that something that requires intervention, or compare that to a situation where it might just require, monitoring?
Well, it's very similar to epiretinal membrane, where it's all about grades. So if we can see it on the scan, if there aren't any concerning features to it, so with epiretinal membrane and vitreomacular traction, there are features that let us know that the retina is not particularly happy about the situation. So in both cases, it's about traction. In epiretinal membrane, it's the abnormal scar tissue that's causing traction on the retina. In vitreomacular traction, it's the gel being stuck too firmly, and as it's trying to shift forward inside the eye, it's trying to pull the retina along with it. And so if a patient says to me, look, I didn't even know I had this. My vision's pretty good. Maybe it's not quite as good as the other eye, but it's still, almost perfect. And the retina itself is looking healthy other than that bit of tugging on it, then, that's something we may be able to watch. But if we're starting to see signs that the retina is not happy with that situation, so that would be things like seeing fluid leaking into the retina or underneath it, so swelling within the retina. It could be something called foveoschisis, which is where we can see the cell layers within the retina are being stretched apart from each other. Or it could be changes in the photoreceptors. So the photoreceptors are the light-sensitive cells, and so they're the area of the retina that's closest to the wall of the eye. And we get this thing called cotton ball sign, where on the scans of the back of the eye, we can see this kind of fluffy-looking material that's appearing underneath the central part of the macula. And all of those things are signs that the retina is starting to decompensate, and that if we don't do something about it, the damage is going to be permanent. Because the retina is part of the brain. So even though it's in the eye, it's physically and structurally part of the brain. And so in the same way that damage to the brain is very serious and very difficult or impossible to repair, damage to the retina can be bad enough that the body just isn't able to heal it. So we want to jump in on these things before that happens. So that's on the objective side of things, what we see on the scan. But of course, the other reason to touch these things is if it's causing problematic symptoms for patients. So, especially if it's in someone's dominant eye, for example, even if it's only very mild, it may be enough that it's distorting their vision. And so I've had patients who, I think, in one case, I had a patient who was a lawyer who was saying, look, I know that when you test my vision, I can still see the 6/6 perfect vision line on the chart, but I can't read fast enough to be able to do my job properly because there's a bit of distortion and a bit of waviness, and it's really making it a struggle for me to speed read. And I need to be able to do that in court. I need to be able to do that in the rooms. It's affecting my occupation. And so that's when we have the discussion about benefits and risks of surgery. And for this patient, it was very worthwhile, and he's thrilled to have the problem solved. Another recent patient was a competitive shooter. And it was the same thing. The distortion of the crosshairs was making it hard to hit a target at distance. And so he said, look, I'm not happy with this. I want something done. Whereas at the same time, I've had other patients who maybe they're aligned down from perfect, but they're saying, look, an operation in the eye doesn't sound great. My vision's able to do everything that I want it to. And you're telling me the scan's not looking particularly concerning. Can we wait? And in those cases, the answer for that patient might be, weighing up the risks and benefits, it's probably okay to just watch this for a little while. And, if it's getting worse, we'll jump in and do something about it. If it's showing signs of stability and it's never likely to get any worse, and your vision is doing all the things that you need from it, then maybe you don't need the big operation at 85 years of age compared to the 50-year-old lawyer who might not be able to do their job if they don't have the operation.
So any kind of surgery has risks attached to it. I think you'd agree. Are there any non-surgical options for someone who may be experiencing VMT?
Not for these conditions. So the three conditions we've all talked about. So for vitreomacular traction in particular, there was some interesting work being done to develop a drug called ochraplasma, which was an injectable drug that was designed to try to dissolve away the extra stickiness between the gel and the retina. And it just didn't work well enough. The trials basically suggested it just wasn't that effective compared to just watching and then jumping in and doing the surgery when we needed to. So that didn't really get off the ground. So at the moment, the only real treatment is surgery. But as you say, these things aren't without risk. And so, vitrectomy surgery used to be a lot higher risk than it is now. So vitrectomies, thanks to the amazing developments that we've had in microsurgical instrument technology, vitrectomy is extremely safe. It's approaching the same level of safety as cataract surgery. Which is about the safest operation that you can have. So it's a lot safer than it used to be, but we still need to be aware that the same as with cataract surgery, it's an operation inside the eye, and there is that vanishingly small but still important risk of things that could do permanent damage to the vision. The other thing that we need to be particularly aware of with vitrectomy is, unfortunately, having a vitrectomy will always bring on cataract earlier than it was going to happen in that eye. So the warning I give to my patients is, look, if we do this operation and you haven't had cataract surgery before, there's about a 50% chance we're going to need to do a cataract operation in that eye within a year after surgery. The other 50% of people might make it to a year without any problems, but they're definitely going to need that cataract operation earlier than they were going to if we hadn't done the vitrectomy. Maybe it'll be 3 years down the track or 5 years down the track, but it'll be earlier than it would have been without the operation. So, in a way, if you haven't had a cataract operation before, you've got to understand that you're effectively talking about two procedures: doing the vitrectomy, and then, sometime within a year, 2 years, 3 years afterwards, having the cataract operation. The next question that you might be going to ask is, can these things be done at the same time?
Yes,
because that's a question I often get as well. And yes, you can do a combined what we call phaco-vitrectomy, which is so phaco refers to the lens, so it's removing the lens and removing the vitreous at the same time. Again, that was quite commonly done in the days when vitrectomy surgery was risky, because it was kind of the feeling that, look, if we're going in, we might as well just get it all done in one go from a patient safety point of view. And also when the outcomes from cataract surgery weren't as good as they are now. So we're talking about an era where the expectation was that you would need glasses after cataract surgery. We're now in an era where the outcomes from cataract surgery are so good that we can reasonably assure most patients that they won't need distance glasses and maybe not even reading glasses after their cataract operation. Having the operation, having the lens removed and the vitrectomy done in the same operation can reduce the accuracy of focusing correction after cataract surgery. So if people are very motivated to be trying to get rid of their glasses entirely, and we're doing the vitrectomy for a reason where I suspect they're going to get back to very good vision afterwards, then it's important to weigh up that risk and benefit. For a patient who says, look, I've always worn glasses, I don't have a problem with wearing glasses after surgery, I'd rather just get this over and done with in one operation. Beautiful, that's great. Let's just go ahead and get both done, minimize the risk. But for a patient who says to me, look, if you're telling me I can have great vision and it's very likely that I'm going to be good enough that I can get good vision for distance and near without glasses, then that's what I want, then the risk is not very much higher to do them as two separate procedures. With enough time for the eye to heal up in between, that we can get more accurate measurements and do a cataract operation that achieves what someone's setting out to achieve in terms of spectacle independence.
Well, Mitch, thank you. It's been an incredibly clear and helpful explanation of what's going on when people start noticing wavy or distorted vision. Before we wrap up, what final advice would you give to someone who's just noticed changes in the Amsler grid, or they're worried about their central vision?
It's sort of like we said back at the start. Macular disease is, macular diseases as a group are, diseases that can seriously impact vision and seriously impact quality of life, and a lot of them are very time sensitive. That we need to diagnose these things and treat these things early to prevent problems. So, if someone is noticing a change to their central vision, if they've got an Amsler grid that they're monitoring, we want to hear from patients early if something's changing. So sometimes patients say, "Oh, look, I didn't know whether I should call. I didn't want to waste anyone's time," that sort of thing. as eye care professionals, none of us are going to be upset with a patient who's noticed a change and wants to get it checked out. We'll actually be very happy if it's something that's quite minor and doesn't need anything done about it. That's fantastic. We're all, everyone's happy. But at the same time, we'll be thrilled if we can catch one of these things early, and save vision that otherwise would have been lost. We're all in this game because we care about people's vision, and because we want to help people maintain their best vision for their entire life. I mean, my little party trick in this is that when I finished my retina surgery fellowship, I got my vitrectomy tarot card tattooed.
I see. I noticed that before.
See that? And yeah, that's my eye with
That's
the
cool.
instruments going in, and the little banner down the bottom is Latin for so that all may see, which is the reason that we're doing this. I'm serious enough about this that I got it tattooed on me, but not everyone else is that crazy. But we're all in this because we want patients to see well. So the take-home message is never be worried that you're wasting our time calling us about these things. If you're worried about your vision, I'm worried about your vision. So get in touch.
And so if somebody wants to book an appointment or learn more about macular conditions or take a closer look at your tattoo, where can they find you and the team at Eagle Eye Surgeons?
So Eagle Eye Surgeons, we're at 2 locations. We've got rooms at Mosman on the Lower North Shore, and we've got rooms in Penrith or Kingswood, the Nepean Health Hub, which is next to Nepean Hospital. So both we're happy to see anyone at both locations. There's a centralized phone number, so if you do want to get hold of us, now I can never remember this. I've had to grab my phone and read it out. But the number for the practice 02 7228 3900. That number gets you both practices. So feel free to get in touch. And the other one that I got on this side, I've got my Eagle Eye Surgeons tattoo, my little eagle. So
that's commitment.
We're a dedicated crowd.
Yes. All right. And of course, there's the website, www.eagleeyesurgeons.com.au. For anyone watching, if you found this conversation to be helpful, please give the video a like on YouTube, because it also helps the algorithm to show it to other people who could benefit as well. And don't forget to subscribe to the channel and follow Eagle Eye Surgeons along on their Facebook or Instagram accounts for updates on new treatments, events, and clinic news. All right. Well, thanks again, Mitch. And thanks everyone for tuning in. Take care. We'll see you again next time.
Cool. See you later.
Bye-bye.